Dear students, welcome back. In the previous session, we have discussed about patellofemoral joint stress as well as the patellofemoral joint reaction forces. Now in this session, we are going to discuss about frontal plane or medial to lateral patellofemoral joint stability. So the patellofemoral joint exhibits the potential for frontal plane instability near full knee extension, okay, as well as for degenerative changes resulting from increased patellofemoral joint stresses in flexion of the knee. So two things we have observed. What are those things? So the patella will have potential frontal plane instability during full knee extension, and the other problem is degenerative changes resulting from patellofemoral joint stresses in flexion. So this problem makes understanding the control of patella frontal plane motion particularly very important. Okay, in the extended knee, how the instability can arise? Okay, so in the extended knee, the instability can arise because the patella sits on the shallow femoral sulcus, isn't it? That too at the superior femoral sulcus, where the bony stability and patellofemoral compression from the quadriceps are reduced in full extension. So because of the physiological valgus that normally existing between the tibia and femur, and also the action lines of the quadriceps, here you can see the action lines of the quadriceps and the patellar tendon, okay, do not coincide. Okay, so for this reason the patella is pulled slightly laterally by these two forces. So if you can see here, so this is the resultant force of quadriceps, and this one is the force of patellar tendon. So in this one is in full extension, so which causes these two forces causes a resultant force on the patella to shift this patella laterally. Okay, yes, the presence of this resultant lateral pull on the patella in extension where the bony stability is reduced, isn't it? Yes, which suggests that soft tissue stabilizers must assume more responsibility for medial lateral stability. So these forces causes lateral pull of this patella. So how can we avoid this lateral pull? So this one is reduced by, this bony stability is reduced by soft tissue stabilizers, okay, and which are very much responsible for medial lateral or frontal plane stability of the patella. Okay, once knee flexion is initiated, okay, and the patella begins to slide down into the femoral sulcus at about 20 degrees of flexion, this medial lateral stability is increased by the addition of the bony stability, because this patella is going to sit into the sulcus. Exactly, then what it is happening, the contact forces between these two is going to increase. That means there, once it is fixed into the sulcus, then the patella is getting some bony stability, and also the concomitant increased compression of the patella again is the femoral condyles. So we have studied in the previous session, during increased flexion, what is happening? The compressive forces on the patella against the femoral condyles also increasing, isn't it? Yes. So compression of patella against femoral condyles here can lead to joint pain. Okay, whether the patella is at risk for instability or for increased compression, the position, mobility and control of the patella in the frontal plane are of utmost concern. Okay, so here what is happening? During extension, this resultant pull of quadriceps and patella tendon causes the lateral pull of the patella. Okay, and during flexion, what is happening? The compressive forces increased against the femoral condyles, which may cause some pain. So to reduce these two problems, the soft tissue structures which are going to play very important role in maintaining frontal plane and or medial to lateral patellofemoral joint stability. So now what are those things? Now we will discuss. So the important factors which are determined by the relative tension in both the transverse and longitudinal stabilizers of the patella. So it is having two restraining mechanisms to reduce these problems, or the transverse group of stabilizers and the longitudinal group of stabilizers. So now we will see that. So Fickett identified that patellofemoral joint is under the permanent control of two restraining mechanisms that cross each other at right angles. So one is the transverse group of stabilizers and the longitudinal group of stabilizers. So now we will see what are the transverse as well as longitudinal stabilizers. Okay. The position of the patella and its mobility will be determined by the relative tension in these two stabilizing systems. Now first one is the transverse stabilizers of the patella. So almost we have already discussed about this. So in the extensor retinaculum. Okay, so transverse stabilizers. So the medial and lateral extensor retinacula join the vastus medialis as well as the vastus lateralis muscles respectively directly to the patella. Okay, this forms the transverse stabilizers, and several investigators have described medial and lateral patellofemoral ligaments, medial and lateral patellofemoral ligaments that may be part of or blend with this retinacular fibers. Okay. So here you can see this medial patellofemoral ligaments as separately in this pic. Okay, there may also be an iliopatellar band attaching the patella directly to the iliotibial tract. Okay, no, commonly it is present at this point. Okay, so which is connecting the patella as well as this iliotibial tract. Okay, iliotibial tract which is present on the most lateral aspect. Okay, so the longitude, this is all about the transverse stabilizers. What are the transverse stabilizers? Medial and lateral extensor retinacula. Okay, that is patella retinacula, which joins the vastus medialis and vastus lateralis muscle, and also medial patellofemoral ligament and lateral patellofemoral ligaments, and also iliopatellar band attaching the patella directly to the iliotibial tract. Okay, these forms the transverse stabilizers. Okay, now coming to the longitudinal stabilizers. The longitudinal stabilizers of the patella are, one is the patellar tendon inferiorly and the quadriceps tendon superiorly, and also the patellofemoral ligaments or thickening of the capsule anteriorly. Patellofemoral ligaments. So normally patellofemoral ligaments, here we can see these are the thickenings. So this forms the longitudinal thing, stabilizer. These are the thickenings of the anterior capsule, which extends from the inferior border of the patella distally to the anterior coronary ligaments and anterior margins of the tibia on each side of the patellar tendon. So here you can find these two patellofemoral ligaments which forms the longitudinal stabilizers. The longitudinal structures can stabilize the patella through patellofemoral compression. The compression is essentially absent in the extended knee. So these longitudinal structures are going to stabilize the patella through patellofemoral compression. That means during flexion. The compression is essentially absent in the extended knee, leaving the patella relatively unstable in the knee joint position. Okay, when some conditions, when extension is exaggerated, what is going to happen? That is called as genu recurvatum. So genu recurvatum, this is hip and this is foot. So what is happening here? Genu recurvatum, the pull of the quadriceps muscle, and the patellar ligament may actually distract the patella. So these two forces are going to distract the patella from the femoral sulcus, which is further aggravating the instability of the patella. So normally during full extension it is having some instability and there is no that much contact between this patella and the femoral condyles because of the action of this patellar tendon and quadriceps tendon. And in the case of genu recurvatum, what is happening? Due to this pull of this excessive pull, we can call it as excessive pull of this quadriceps muscle and the patellar tendon, again which is going to distract this patella from the femoral sulcus, which is going to aggravate the instability of the patella. Okay, there are also other some of the longitudinal structures and other effects of the longitudinal structures should be examined here. Both the transverse and longitudinal structures will influence the medial lateral positioning of the patella within the femoral sulcus, and the so-called patellar tracking or path of patella as it slides down the femoral condyles within the intercondylar notch. All these things should be we have to examine this. So now we will see how medial lateral positioning of the patella is going to take place. All the passive and dynamic transverse and longitudinal stabilizing mechanisms of the patella can influence the medial lateral position of the patella. The passive mobility of the patella and its medial lateral positioning are largely governed by the passive and dynamic pulls of the structures which are surrounding it. When the knee is fully extended and the musculature relaxed, some of the investigators have concluded that the patella should be able to be passively displaced medially or laterally, no more than 1/2 the width of the patella, and that excursion should be symmetrical. Okay, so however, others have found their either relationship to hold true or have found considerable variations among individuals. If any imbalance in passive tension, okay, imbalance in passive tension or changes in the line of pull of dynamic structures will substantially influence the patella. And this is very much true when the knee joint is in extension and patella sits on the relatively shallow femoral sulcus. Abnormal forces, however, may influence the excursion of the patella even in its more secure location within the intercondylar notch during knee flexion. So that means all the forces should act in a particular way to maintain the patella in its position. If any abnormal forces which are going to act on the patella, definitely it causes a dislocation of this patella from its position. Okay. Yes. Now we will see what are the medial and lateral forces on the patella. Okay, what are the forces acting on the medial and lateral sides on the patella? So during active extension or when the quadriceps muscle is passively stretched, okay, and the patella is pulled by the quadriceps, that means the patella will move up. Okay. So the force on the patella is determined by the resultant pull of the 4 segments of the quadriceps. This is the resultant pull of the 4 segments of the quadriceps, that is called as FQ. And by the pull of the patellar ligament, that is PT, patellar ligament. Since the action lines of FQ and FP do not coincide, that means it is making some angle. Okay, so the patella tends to be pulled slightly laterally by these 2 forces. Okay, anything that might increase the obliquity of the resultant pull of the quadriceps or the obliquity of the patellar ligament in the frontal plane may increase the lateral force on the patella. Okay, an increase in this lateral component may increase the compression on the lateral patellar facet as it pushes harder into the lateral lip of the femoral sulcus in knee extension. Okay, or the lateral aspect of the intercondylar notch in knee joint flexion. A large lateral force on the patella may actually cause it to sublux or dislocate of the lateral lip of the femoral sulcus when the knee is extended. Okay, however, even a very large lateral force on the patella would be unlikely to result the dislocation once the patella is in intercondylar notch also. Normally in the intercondylar notch is the we can call it as at the safest position for the patella. That means here the patella is exactly fixed into the notch. That means the bony congruence and the bony stability is great in that position. Even in that position also, if any abnormal or very large lateral force on the patella, which likely to cause dislocation of this patella. Okay, so the pull of the vastus lateralis muscle is normally 12 to 15 degrees lateral to the long axis of the femur with even greater obliquity. okay, in its lower fibers. So the pull of here vastus lateralis. So here the pull of the vastus medial is longest. Okay, that means we have discussed, isn't it? The vastus medialis is divided into two components. One is VML and VMO. So the oblique fibers are present at the lower end, that is the lower fibers of that muscle. VML is the upper fibers, which is making 15 to 18 degrees medial to the femoral shaft, and with the vastus medialis oblique, which is pulling 50 to 55 degrees medially. So all these things we have already discussed. Since these two muscles pull not only on the common quadriceps tendon, but these two muscles also exert a pull on the patella through their retinacular connections. Okay, and complementary retinacular connections and complementary function is very critical here. So that is, there is any relative weakness of the vastus medialis, especially at the VMO, may substantially increase the resultant lateral forces on the patella. That means if the medial side is weak, so then the opposite side forces are definitely large because of this weakness. Normally these two forces should be balanced. So one is weak and this becomes the unbalanced force, and this will pull this patella towards the lateral side. Okay, so this obliquity of the pull of quadriceps muscles and patellar tendon can increase with problems other than imbalance between the vastus lateralis and vastus medialis. So we have seen some of the conditions, that is genu valgum. Genu valgum increases the obliquity of the femur and concomitantly the obliquity of the pull of the quadriceps. Okay, and femoral anteversion, that is internal femoral torsion in the older child or adult generally results in the femoral condyles being turned medially rotated relative to the tibia. This creates an increased obliquity in the patellar tendon that may also be seen with lateral tibial torsions. Each of these conditions can predispose the patella to excessive pressure laterally or to subluxation or dislocation. So that means in genu valgum and also this femoral anteversion, in these two conditions, so there is a chance of excessive pressure laterally, and which causes subluxation or dislocation. So how can you assess this kind of pull of this quadriceps and patellar tendon? It is done by, we can clinically assess this angles by a common assessment called as by knowing the quadriceps angle of knee, or Q angle. That Q angle we can see in the next session. Thank you.